So one of the commonest classification which is used in spondylolisthesis is Marchetti. But what we actually see in the OPD is this. We see the X-rays and we classify the patient into low grade and high grade listhesis. And this is of very importance from the practical point of view, because the treatment between the high grade and low grade listhesis differs vastly. So let us start with the first category, the low grade. And one of the commonest examples of low grade listhesis is seen in adults. And these are of two types, the degenerative and the spondylolytic. The degenerative listhesis usually occur in elderly females, and they are primarily because of the intersegmental instability because of the disc degeneration. And what we have to remember regarding the treatment part is usually the leg pain or the radicular pain is because of the compression of the traversing nerve root, which gets pinched under the medial part of the hypertrophied facet. So when you're decompressing, you try to decompress this part properly till you reach the inferior margin of the inferior pedicle. The second variety is the lytic spondylolisthesis, and this is basically because of the defect in the pars interarticularis. And the radicular pain in this patient is usually because of the compression of the exiting nerve root. And this is because the pars defect tries to heal itself by formation of a fibrocartilaginous tissue there, which compresses on the exiting nerve root. So whenever you're decompressing a lytic listhesis, your primary focus of decompression has to be the exiting nerve root. So normally the degenerative spondylolisthesis, if you is likely to get missed when you do just look at the MRI, and because the MRI is done in supine position, and it's very common for especially freelancer visiting spine surgeons who get WhatsApp images on the images of the patient, and they're invited to do a lumbar canal decompression for lumbar canal stenosis. And in such cases, one should have to look very vigilantly at the axial images. And if you see a fluid within the facet joint like this, and this is a sign of fluid collection in the facet, the distended facet sign, and this is one of the indicators of spinal instability. And you always need to do a standing flexion and extension X-ray, the dynamic X-ray in loading position to check visibly for the instability. So this is one very important point which we should not miss for any case of lumbar canal stenosis. Now, what are the symptoms? Majority of the adult spondylolisthetic patients, they may come to your OPD for some other reason, and the finding of listhesis may be just an incidental finding. And many of these patients, they are asymptomatic, but they may present with mechanical low back pain, usually an extension catch because of the facet arthritis, or they may have a radicular leg pain or a claudicant leg pain. So back pain in adult spondylolisthesis, usually the degenerative variety is more on extension or rising from the sitting position. And the severity of the back pain is not related to the degree of slippage. That means if you get a high grade listhesis, that means the patient need not have a very severe back pain. The back pain in a previously asymptomatic patient is usually due to disc degeneration. And the back pain gradually improves once the complete disc space collapse occurs and the L5 and S1 start touching each other. So what is the natural history of adult spondylolisthesis? This is very important. Majority of the low-grade spondylolisthesis, which include the degen spondylolisthesis, they usually don't progress. Only 30% of the slips, they progress. There is no correlation between the clinical symptoms and the slip progression. 75% of the patients who are normal neurologically, they do not deteriorate with time and they respond very well to conservative treatment. Only patients with severe neurological claudications or bladder bowel symptoms, they have a poor outcome with conservative treatment and they gradually deteriorate with time. So surgery is indicated in such patients. So what are the surgical options? The fusion surgery is the most important one. And I usually try to select patients who have radicular pain, leg pain, or the claudicant pain, along with back pain. These are good candidates for surgery. I usually don't prefer to operate just patients with just back pain and without any demonstrable instability on the dynamic X-rays. So the commonest procedure is the TLIF procedure, which can be done by open technique or a MIS technique, as Vishal Peshattiwar is going to talk about later. And the second option, I think, is the non-fusion one, where instead of, it's similar to the pedicle screw rod system, but instead of the rod, we put flexible polymer cables out there. So these allow a limited mobility between they limit the motion between especially the extension between the segments, and this may prevent aggravation of listhesis post-operatively. But what I think is more important nowadays is the decompression only procedure, or the UL body procedure, which is unilateral laminotomy for bilateral decompression. This procedure is usually advocated for patients with leg pain only, no back pain, and it is usually working very well for grade 1 stable listhesis, which do not show any mobility on dynamic X-rays. Now, coming to the second part of the talk, which is high grade listhesis, I think, and this is more important, the basic indications in a high-grade listhesis is always the risk of sleep progression. Sleep progression is very important, and in adults, the sleep progression is rare because the adults, they usually auto-stabilize or auto-fuse with as the time passes. And the main complaints are usually radicular, and they can be treated with root blocks or simple decompression. The sleep progression problem is more of a problem in children and adolescents, and the younger the patient presenting in your OPD with the symptoms, the more likely the risk of sleep progression is there. And clinically, one has to remember that yes, we have all those other parameters like sleep prognosticator parameters like pelvic incidence or the sleep angle, but sometimes just looking at the X-ray and looking for simple signs may help you to determine whether the patient is going to have this progression of sleep at a later date. So one of such signs is the evidence of lumbosacral dysplasia. I think many of the AP X-rays, they will show spina bifida occulta. Normally, spina bifida occulta, the incidence in normal patients is 2.2%, but in the high-grade listhetic patients, it's almost 42%. So if you see a patient of high listhesis, a young patient of listhesis with a spina bifida occulta, you might expect that this is a patient who is likely to progress later on. Then other signs are absent lamina. Then we have the facet signs where the hypoplastic facet is there, L5S1 or L45, and hypoplastic transverse process. Obviously, we have later changes like sacral dome doming or the trapezoidal L5 vertebra. So this is an X-ray which shows a spina bifida occulta, and if you see an X-ray in a listhetic patient like this, try to get the patient for more follow-up, frequent follow-up, and try to discuss with the patients as rigorously as possible. Another sign you can see here that the L4 L5 transverse process is significantly smaller as compared to the L4 transverse process. This is a hypoplastic transverse process, another sign of lumbosacral dysplasia. Again, blunting of the sacral implant or blunting of the posterior margin of the L5 vertebra. These are again early signs of high-grade dysplasia. So to understand the treatment of spondylolisthesis, I think we need to understand the mechanism of how it works. First thing we have is the listhesis or the toppling of the L5 over the sacrum. And once this happens, there is spinal imbalance and the compensatory mechanisms that come into place, which is exaggerated lumbar lordosis. Then we have thoracic hypokyphosis. If the spinal balance is not restored with these maneuvers, then the pelvis, it goes into retroversion, the hips, they go into extension, and the knees, they go into flexion, ultimately the patient having a crouched posture. So this is one of the most commonest or most important classification, the spinal deformity study group classification, which is useful in the treatment plan or the decision making of treatment in spondylolisthesis. In a high-grade listhesis, which is more than 50% of the listhesis, you first look at the pelvis, see whether the pelvis is balanced. If it is balanced, it's much more easier. But if it is not balanced or if it is retroverted, then you have to look at the balance of the spine. And if the spine is not balanced, obviously it is a more severe listhesis which needs to be corrected. And this particular chart is very important in determining the plan of reduction of spondylolisthesis intraoperatively. What it means is that you have to try to correct the retroverted pelvis first, before you try to correct the spinal imbalance by translation. So these are the various types of high-grade spondylolisthesis, and there are numerous angles which are available, and this really confuses me a lot of times. We have the slip angle, sacral slope, pelvic tilt, and the pelvic incidence. But when you're sitting in front of the patient in a very busy OPD, you don't have a chance to measure all these angles, and the patient's relatives are waiting to discuss with you. So what I do, I usually look at the X-ray, plain X-rays, and try to see the parallelism of the sacral dome with the L5 vertebra. If there is an angulation, this indicates there is lumbosacral kyphosis, again a bad indicator. Then the second thing I look at is the verticality of the sacrum. You draw a line along the posterior margin of the sacrum and see how vertical it is. If it is too vertical, that means the sacrum, that the pelvis is retroverted. Again, another line you draw from the anterior superior relaxed spine to the anterior margin of the acetabulum. These are just rough indicators. And if you see it is not vertical, if it is slanting posteriorly, this again indicates a retroverted sacrum. And the last and the most important, which is a very difficult thing to calculate normally in the OPD X-rays which we get, is the pelvic incidence. What I look for is see whether the head of the femur is lying in line with the vertebral column or the spinal column. If the head of the femurs, they are placed much ahead than the vertebral column, that means the patient has a very high pelvic incidence. And these are the patients who are at high risk for progression of listhesis. So there are numerous surgical options which are available. They extend right from in situ fusion to spondylectomy by Gaines procedure. And the surgical choice of this patient has to be tailor-made depending on the findings which we get in the patient, also along with the complaints which we have with the patient. And basically we have got two options. We have got in situ fusion on one side, one end of the spectrum, and a reduction and fusion at the other end of the spectrum with a lot of variables in between. And reduction per se, we can have a complete reduction or a partially reduction, partially reduced listhesis with extended fixation. So in situ posterolateral fusion is, I think, a good indicated patient is a young patient with no neural symptoms, a good spinal and pelvic balance, but it is not recommended in patients with very high or wide disc space. But the problems are the very high rate of pseudoarthrosis because the lesser surface area is available for the bone grafts, and the grafts, they are placed under tension, and therefore they have a tendency to resolve with time. So even if you get a good fusion, the graft may just, the fusion mass may just disappear with time. Secondly, slip progression is also possible in spite of solid fusion. It occurs in almost 26% of the patients. And lastly, even though everything is all right, the patient mainly comes for the cosmetic deformity, especially these young girls, they come for a cosmetic deformity and they're not happy with the end result. So reduction definitely, I think, is something which is much more advantageous. And why? Because it improves the fusion rate, it allows direct neural decompression, it restores the sagittal alignment, and it improves the gait and cosmetic appearance. And the principles of reduction are based on good soft tissue releases and correction of the pelvic retroversion by proper positioning of the patient, which is hip and the knee extension. And one of the maneuvers which we do in during reduction is to push the sacrum downwards and inferiorly to get the anteversion of the pelvis. And then you reduce the upper vertebra backwards. So the primary aim of any reduction is to correct the lumbosacral kyphosis, that is to correct the angulation, not to correct the translation. And the secondary aim is to correct the translation as much as possible, not to force too much upon it. So what are the disadvantages
Pramod,
of reduction?
Could you just...
Yes, last three
Pramod, could
slides.
you just sum it up? We're running short of time, Pramod.
3 slides, last 3 slides. Yeah. So reduction, sure. I think disadvantages, technically it takes a longer operative time. There is a higher chance of neurological deficit, nearly 50%. And there is a study by Petraco, I think, where he did a biomechanical study on the L5 nerve root strain, and he found out that during the first half of the reduction only there is strain of only 29%, whereas 71% of the strain is in the second half of reduction. What it means that the reduction during angulation correction is not that strainful, but reduction of the later half of the translation can put the L5 nerve root at more jeopardy. So complete reduction is usually high risk for neurological deficit. So again, this is a short sum up for a patient with a balanced pelvis and spine. You don't have to do any reduction maneuver, just postural reduction is there. Whereas patient with an imbalanced spine and pelvis, you have reduction is mandatory. And I'll just keep this. So fixation, I think whether monosegmental or multi-segmental, I think the biggest proponents of monosegmental are Harms and Shuffle-Barger. And why they do it? Because they get a complete reduction all the time, complete anatomical reduction. Whereas rest of the world, I think, who are happy with a partial reduction, they have to go for a supplemental reduction like L4 screws and pelvic fixation. So why L4 screws, dysplastic L5 pedicles, access to L5 pedicle is difficult. Instrumentation to L4-5 provides a better stability, and many times the L4-5 facet is also hypoplastic. Why pelvic fixation? Because they protect the S1 roots. And this is the second last slide. Anterior column support is mandatory when the reduction is attempted and there is a large disc height. It provides a greater stability with a higher fusion rates. But sometimes the disc space is not available. In such cases, we can do a delta fixation or a transvertebral screw fixation or a Bolmer's technique, which Kshitij is going to talk about. These are also alternative ways to provide anterior column support. To summarize, I think it is important to detect early younger children who are likely to progress. We have to look for signs of dysplasia and look for pelvic incidence and slip angle. Determine whether reduction is necessary or not. It is not necessary if the pelvis and spine are balanced. The primary aim of reduction is to correct angulation and try to get as much translation as possible. Don't force too much upon it. If there is an incomplete reduction, extend the fixation to L4 and the pelvis. And anterior column support is important either with a cage fixation or a delta fixation. Thank you.